Okay, so they come up with spinal motion restriction. It's just a new word for holding C-spine. Okay, why do they have to create new words? I don't know, but they do. Okay, and then spinal cord injuries are quite rare, really, most of the time. I mean, there's not a lot of true spinal cord injuries when we look at it. We look at the spinal column and the nervous system. Remember, the spinal column helps protect the spinal cord, right? So it's surrounded by bone, and then it protects the spinal cord. We'll talk about the spinal column injuries to the vertebra and then the cord injuries, okay? So there's only two different things that it could be. And the spinal nerves, the nerves come out. These yellow things on bones here represent the nerves coming out. Okay, so anytime that you have damage to the nerve, a spinal nerve, the spinal nerves are the ones that we can't put back together again. Okay, peripheral nerves we can put back together. But when you have damage to a spinal nerve or any nerve, you know, you're going to have a deficit. You're going to lose sensation or something. So if someone has a damage to a nerve, like I did one time, temporary. That was thankful for that. But on my shooting hand, of all things, I was in this handcuffing class, and I don't know. I guess it's because I was an E5. I always got the instructor. So we were handcuffing, and I made a mistake of leaving the hook open on one of my handcuffs. He was being a little rowdy, and so I left the hook open. Anyway, he grabbed that hook, and he was going to stick me in the neck with it, which was my mistake. Okay, I shouldn't have left the hook out. It's a weapon. Anyway, he went to hook that in my neck, and so I dropped down to the ground, and when I did, he twisted the chain, okay, around one of my fingers on my shooting hand, okay, and then we went into this sort of short fight over it, because he was really trying to stick me in the neck with this hook, and I was down there, and I said, hey, you know, we can do this all day, but with you being the instructor, I don't know, but in real life, I would really hurt you right now, you know, and so you don't want to be singing soprano, you better let go of me, because I'm about to hurt you really bad. So he let go, but in the end, he temporarily damaged the nerve, one of the nerves in my trigger finger, and I couldn't feel that for weeks. So all the qualifications in shooting I was doing, I couldn't feel my trigger finger, which was be a big deal. You know, you can't feel you shooting. So that nerve damage was temporary, something like that. When you remember when telling me about blood pressures, right? Manual blood pressures. There's a nerve that runs down through here. That if you put that manual blood pressure on too tight, that cuff on too tight, you can cause damage to this nerve right here, which can cause a deficit in the arm, right? So we have to be careful of that. Anyway, if we look at the mechanism of injury and we look at things and we say, hey, there could be a spinal cord injury here, we have to be very careful with the patient, okay? If that patient's in a car, let's say they're in a car wreck and we really suspect there's a spinal cord injury, we will cut the car completely away from the patient, where there's just patient there sitting in a chair. We'll take everything, whatever we have to take away, we'll cut that away from the patient without having to manipulate them. You guys will learn later, because we're going to do this. Well, we did it last year, I think. We did spinal immobilization out of the car.
Mm-hmm.
Yeah.
You grab Maddie's hair and we're fighting them.
You grabbed Ashley and put her in a chokehold.
Yeah, that was it. Anyhow, you already know then that taking a patient out of the car, it's very easy to manipulate their spine. So in real life, they would cut the car away. They take the doors off, they take all the A-frames off, they push everything out of the way in order to not manipulate the spine. Make it a lot easier. So just a quick anatomy. You know, all the nerves, they communicate and they control functions, okay? Without them, we couldn't have muscle contraction, including the diaphragm. We couldn't have coordinated movement, pickups, things, couldn't swing a golf club, anything like that, okay? So it's a big thing. We have to be cautious with the nervous system and the nerves when we look at them. The brain, of course, the spinal cord connects directly to the brain stem, right? Up through the foramen magnum. And then we already know this. We have voluntary nerves for skeletal muscles, just like we talked about. Autonomic nerves, like for the sympathetic and parasympathetic nervous system. The heart has its own set of nerves to it. Respiratory muscles, right? They're automatic, so we have no control over it. So it's like smooth muscles. What is the sympathetic? Like a sympathetic response. What would that do?
Increase heart rate.
Increase heart rate.
Increase breathing. Breathing.
Dilate the pupils, slow the gut down. Okay, parasympathetic.
Reverse.
Opposite all that, right? Slow the heart rate down. Right. The sympathetic nervous system will also stop the release of insulin. That's something important to remember as well. Yeah. Okay, so skull, face, cranium, 33 vertebrae. Okay, they're all formed together with ligaments. If you see up here on bones, you see the ligaments in between here. It acts as a cushion. Okay, because we run and we jump and all these different things, so we have to have a cushion there as well, with the disc, separated by the disc. And then something that I hope you're familiar with, the different breakdowns. The top 7 are the cervical C-spine or cervical spine. They're the smallest in size, so they're easily more fractured. Okay, plus they have a bowling ball sitting on top, so they're easily fractured. You have the thoracic spine, which they're physically bigger. Okay, then what? The lumbar, the lower back. Okay, a lot of disc injuries come in the lower back because of improper lifting. These discs rupture, and then we have the sacral and coccyx. They're fused together. So keep that in mind. Those are always good test questions. You know, how many cervical vertebrae, how many thoracic. The C7 is this knot. Everybody has a knot right here on the back of the bottom part of your neck. That would be C7. So when you go to palpate the cervical spine, you know that's C7. In its trivia. A lot of the spinal cords, and I'll let you read through this as well, because these are ways to sort of calculate the injury site. It doesn't matter in the great scheme of things where the injury site actually is, right? We just know that we possibly have a spinal injury, okay? But, so the motor tracks, the different tracks of the spinal cord, the motor tracks carry impulses to the same side. Pain carries impulses to the opposite side. The light touch that we have is the same side of the body. So just read through that. Be sort of familiar with it. I can't even imagine. I know on the National Registry you won't see any of that. I mean, I almost can't say for sure, but you know, that's really trivia information. Sort of like, you know, when we have a right-sided stroke, where's the deficits?
Left side.
Left side. That's really trivia. Because if we have deficits on the left side, and we know to take care of the left side no matter what, where the stroke is. Same way here, we're going to take care of the spinal cord. Most of the time, like 85%, this says with spinal fractures, okay, there's no neurological deficits, okay. However, if we improperly handle the patient, that's where we can create the deficit, okay. So a lot of patients they may have broken backs, right? You may have a Tony Romo fracture. You know what that is? Have you heard that yet? The Tony Romo fracture? He fractured one of these. He fractured the body of one of his vertebrae. They're bone, right? So they fractured just like a bone.
Yeah.
So he fractured this, the body of that. Everybody calls it a Tony Romo fracture now. Okay. However, you can fracture any portion of this. The processes, the spinal processes, either to the posterior or to the sides, okay? So you can fracture these processes, okay? So if this is fractured and this process, just imagine this, if this is moved over some, but there's no deficits, right? That vertebra is just moved over, and then we jostle the patient around, we move them too aggressively, and it moves that vertebra over, then it catches a spinal nerve. Sure, see how that would work? So we have to be careful that we don't have a patient that has no neurological deficits and we create a neurological deficit. On the side note of that, that's why we do CMS checks before and after. Before we move the patient, after we backboard the patient, right? Because we can document no deficits, okay? And that has come up before. I had high school students who sort of called and they were wondering if they were going to have to testify when they were doing the write-outs because the hospital was blaming the EMS for not properly backboarding this patient, and they had neurological deficits from it, but it wasn't the EMS. Something happened when they removed the board or something. Okay, so because the EMS crew, well, they had witnesses, and they had it documented that there was no neurological deficits when they had the patient. So that's very important to document in something that could be a spinal related injury. Hey, there's nothing wrong with that, you know. And then you get all your witnesses together. Okay, so a number of things that could take place. Falls, we know that. Drunk, falls down the stairs, break his back, hurt. Someone jumps off a diving injury into a swimming pool. They hit their head, maybe a compression fracture over the C1, a whiplash type thing where it goes back and forth. Sort of a hanging. You know, just so much trivia today. You know, just the trivia. If you don't tie the right knot, like this guy here, it has like 13 loops and all this. It's a special knot to hang somebody with. Okay? If you don't tie the right knot, guess what? Or the person hanging themselves doesn't tie the right knot. Guess what they end up doing?
They just choke themselves.
They strangle themselves to death. The cause of death would be strangulation, because that knot is designed to actually break the neck at C1 and C2. Without that knot, they actually strangle. Sit there and sort of kick, strangle. Okay. The funniest hanging I've ever went on. You know the level of, that thing I put up there, that level of stupidity? Okay? This old guy was trying to hang himself with an extension cord from a kiddie swing. Yeah, the family and everybody was so panicked, they left old boys hanging there on the kiddie swing. So when we pulled up, he was still there. But he wasn't dead because not, it was just, it stretched, the extension cord stretched. And his knees were almost, it was really on the ground, his feet were on the ground, because it's a kiddie swing, it's only like this high, right? And he was sitting there, they fractured his larynx, I think, but we had to intubate him. But they, so he was just hanging there on this extension cord. And now I look back on that and think, man, you need to have YouTube or something, right? I mean, something to say, hey, this is how you do this. But I just went up with my pocket knife and cut the extension cord. He dropped about an inch and he looked up at me and he was having some respiratory problems. So just I think it got this fractured his larynx or made his throat swell up a little. So we tubed him. I'm like going, holy cow, man! Don't know how to do that, do you? Other type of falls. Penetration, stabbing, shootings, okay? So we have two different types of injuries. We have fractures to the bone, right? And then we have cord injuries that's going to cause a loss of sensation, or they're going to cause a deficit. Okay? So when we look at this, remember that, and you can do a couple of things. You can partially cut the cord, the spinal cord. You can transect the cord, which would be devastating, depending on the part of where you transected it at. Any spinal cord injury above the level of the nipple line, which would be about right here, will take out the diaphragm. So this patient's going to stop what? Breathing. So they're going to stop breathing. If there's a deficit above the nipple line, they're going to stop breathing. Okay, so those are things to look out for. The bone part of this, okay, so you suspect I think this is going to come up in the slides, but I got bones right here, and I'm just ready to feel his vertebra. But they, remember that Mechanism of Injury movie where they were hitting the spine? Where the fire guy came up and goes, "Does this hurt?" Y'all remember that?
No.
He's touching the spine. Goes,
I don't think we ever saw that.
yeah, with the helicopter across the road.
Wait, what?
Well,
Was that here?
I don't know, but we'll watch it again because it's funny. But anyway, so you have this patient that you suspect that has a spinal cord injury, a spinal column injury. Okay, what you would do is you would, in your skills testing, you would palpate the back. So you would start at the very top of the C-spine and palpate each process as you go down the back. So when you do this, you're starting up here. You would check the C-spine before you would put the C-collar on. Okay. So you would palpate the neck before the C-collar, and you would palpate each one of these processes, okay? And then when you check the back, when you log roll the patient over to put them on the backboard, you would check the back. You'd physically look at it to make sure there wasn't any glass or things that would stick in it before you laid them down on the board, okay? And then you would run your fingers down the processes on the back, okay? I would say almost all the time, probably 90-something, upper 90-something% of the time, if you're palpating the spine, these processes, and it comes over here and you have point tenderness, or you come across here and they say, "Oh, that hurts," that vertebra is fractured. Okay? Most all the time, that's going to be fractured. So that's why we do that. That's little, you don't hit them, but you just run it down. And I never ask them if it hurts. What I do is I say, "I gotta feel your back," and I come over here and I watch their face and see if they have a grimace or something. Okay. Now the pain, spinal pain is in the midline. Right? You can have back pain, okay, but if you have pain here, okay, or up here on the sides, that's called paraspinal pain. If you have what we're interested here when we talk about these spinal cord injuries is pain in the midline. You hurt here in the middle as you ask, you're looking, okay? Because this would be spinal pain. Over here to the side, just on these big muscles in the back, that's paraspinal pain. The same way here, if you ask the patient if they have neck pain, you want to ask them if they have neck pain in the center of their neck, not on the sides. On the side of the neck is paraspinal pain. That's muscular. That's not spine related. Okay? Everybody good? So do that touch test. When you check the back, check these. I've had a handful, and only one wasn't fractured. All the other ones, it broke their back. It's really considered a broken back when the spinal column somewhere is fractured. But if there's no cord injury, then there's no neurological deficit. So the cheerleaders have this a lot, by the way. They break their backs. They throw them up in the air. Squirrel! Right? They fall down and they land right on their butt, and they have compression fractures in their thoracic spine usually. In their lumbar or thoracic spine. Yeah. Ran on a few because they, like you used to do the college football games, and they throw them so high and you're going, oh, we better catch them. No, they break their back. I had one guy slide off the roof of his house, landing on his butt. He had several compressed fractures in his spinal column. Okay. So we look at this. The other thing that we want to look at, make sure that they're not in neurogenic shock, right? So if they're hypotensive, remember neurogenic shock, the skin is opposite. This is opposite. In neurogenic shock, the skin is warm, dry, and the pulse rate is normal. In hypovolemic shock, what is the skin?
Cold and clammy.
What about the pulse?
Weak.
Weak, rapid, right? So it's opposite. This you will see in like test questions and stuff. They're asking you have this patient, blah, 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 and they'll give his skin is warm and dry, and his blood pressure is, 80 over 60, and they're leading you towards neurogenic shock. You have to remember the difference in here. The skin is warm and dry, and the pulse rate is normal. That's a big thing as well.
For neurogenic shock, would their skin be like flush, or would it be like white and gray? For neurogenic shock.
Normal. Warm and dry. Pink.
Pink. Okay.
Okay. So it's the differences on how the vasodilation is. Just the biggest part is just to remember the differences with neurogenic shock. Warm, dry skin. Okay. Pulse rate normal, but pressure low. So it's totally opposite of what you think. Right? Okay, back to the track. So these go in. How you say this word here? It's just an injury, incomplete spinal cord injury to one side. You loss of motor sensation, loss of pain sensation on the other side. To keep it simple, what you do on this. Like if you have a significant mechanism of injury and you maybe suspect a spinal cord injury, the first thing I do, let's say I have a patient that is ejected from a vehicle, so it's a high mechanism, high suspicion of spinal cord injury, okay? The first thing I ask them after the ABCs is, can you move all your arms and legs to make sure they're neurologically intact? Can you move all your arms and legs? Okay. Then we can downshift the gear. Okay. As long as they're moving. If they can't move their arms and legs, then there's a problem. And then second thing we jump into is sensation. So you don't have to do a full exam. You grab their hand like you're checking the pulse. Can you feel this? Can you feel me touching your arms? Can you feel me touching your legs? Yeah? Okay, good. Can you move all your arms and legs? Yeah? Good. Very, very rapid physical exam in like a size up to determine whether or not you have a spinal cord injury. Okay. So, like we talked about, crashes, blunt force, gunshot, electrical, don't forget electrical. Electricity contracts all the muscles. It can contract those big back muscles around the spinal column and fracture those. Okay? There's been several documented cases of fractured femurs from getting into electricity. Those quads and everything contract so tight it fractures the femurs. Okay. Same thing with the spinal cord. And the mechanism of injury just sort of ups your suspicion a little bit. Hey, there could be, right? Because remember, the transporting part of this, if you have a spinal cord injury, you need to take that patient to a level 1, right? They need to go to a level 1 hospital. That's why you make all these judgment calls. So if this person can move all their arms and legs and they had some good sensation, then hey, I probably won't take them to Baylor or Parkland, right? Take them to a level 3 or something, as long as that's all what's wrong with them. So good, nice front-end car crashes, head-on collisions, especially left front. The left fronts have a very high suspicion. A lot of energy is sort of transferred from car to car, and then if they're going 70, both of them are going 70, then you have essentially a 140 mile an hour collision. So very high suspicion. Okay, so just like on your skill sheet, the first thing you would do is hold C-spine, because of the fact that we talk with our heads. Okay? Yeah. Everybody says, don't move your head. Okay. You know? No, really don't move your head. Yeah, okay, no problem. You know, so we come up, tell the patient, hey, I'm gonna grab hold of your head, keep you from moving it, and hold it sort of tight, because the first thing they're going to do is go, okay. They don't move their head. So hold here. Don't pull traction on it when you hold C-spine, so don't pull up. Just hold C-spine. It is a critical criteria on the skill sheet. So you have a partner helping you doing the spinal immobilization. If you don't direct that partner, you know, VSI seems safe. If you don't direct that partner to hold C-spine, the next step, you automatically fail. The skills examiner is going to go boom, and then you have to redo the skill. Okay, so make sure that's one of the first things that you do. If you need to open the airway in any trauma patient, remember it's the jaw thrust. Okay, and then you would hold this manual stabilization, the C-spine, throughout the assessment and the full immobilization process. We'll get to that in a little bit when we practice skills, but until they're completely immobilized, that means their head is taped down, okay, then you can let go. But during the other process, you have to have someone holding C-spine. In the skills exam, there's going to be like a ghost there holding C-spine for you, but you verbalize that. Okay, I have Casper holding C-spine. We'll talk about that in a bit. But maintain C-spine. Okay. So you're wondering, do I need to hold C-spine? Do I need to consider spinal immobilization in trauma? Any altered mental status? Why in any altered mental status? Let's say we got, Danny the drunk. Okay.
Oh, because they might be moving around, and so that can possibly cut the spinal cord.
Not really. They can be moving around, but anybody can be moving around. Why an altered mental status? Don't overthink it. It's actually quite easy. Let's say I wreck my car and you see 500 beer cans in the front seat of my car. Hmm?
They don't listen.
Oh, they don't listen, that's for sure. But what else?
They don't feel like pain.
Really close. That's one. They don't really feel pain that well. Okay,
So do you won't feel any sensation?
but they're altered. Let's say they're completely sober, but they're altered.
Or they can't follow directions.
That is true, to a sense, but it's not quite what I'm getting at. It's real easy. Real easy. Oh yeah, okay. They may not have the mentation to tell you whether or not they hurt. So all the spinal stuff that you do, the test that we're about to look at,
They feel no sensation.
well, no, but they may not be able to tell you that they may feel sensation, but they may not be able to tell you that there's a problem.
Oh.
Okay, just because they have an altered mental status. Does that make sense? Okay. So, any painful distracting injuries? What would be a distracting injury? yeah, femur, the bone sticking up through your legs. Okay, so both bones sticking up there, that's pretty distracting. You're sitting in there, you're looking down, your femur's going, they're not supposed to be out here. You know, that would be distracting. So that would distract them from giving you a good neurological evaluation. Okay? And then if they can't communicate, if they can't effectively communicate with you, then you would go ahead and do that. But when in doubt, just like splinting, when in doubt, splint. When in doubt, put them on a backboard. Okay? Now backboarding over the years has decreased. Back in the day, we used to backboard everybody. Okay? If you fall out of that chair, we're going to backboard you back into that. I mean, a simple fall out of the chair. Okay? Backboard, seat collar, everything. It was ridiculous. Okay? There's no index of suspicion that you're going to have a spinal cord injury unless you're a gazillion years old. But we backboard everybody. So over the years, and several years ago, they've actually, some EMS agencies have taken backboards off of the ambulance. They don't want you backboarding them. One, because of the over manipulation of the spine, okay? But two, you take them into the ED and they sit there and they lay on the board, right? And they lay on the board and they lay on the board. They're not really worried about the comfort, but they're worried about pressure sores. They've discovered that these pressure sores, you know, where you sit in one place for hours on end, right? You develop a pressure sore, you decrease circulation. So they're concerned about that. So they're really going away from a lot of backboarding. A lot of EMS agencies are doing some type of spine clearing type protocol now, or they're really looking at the more higher suspicion. So if you fall out of your chair, you don't have any midline back pain, right? You don't have any sort of signs and symptoms of neurological deficits, we're not going to put you on board. But used to, everybody went on the board. So they've educated and trained, and now we're able not to backboard so many people. Before, lack of education, lack of training, we just backboarded everybody. Okay? Anyhow, and two, if they're high priority, of course we want to always, when we're doing our trauma assessment, we always want a rapid transport. Unresponsive, they're unable to obey command, they're having breathing difficulties, or there's an obvious spine, there's deformity or tenderness to the spine, right? Neurological deficits, we want a rapid transport. So we maintain spinal mobilization. It's not really in order, okay? You would immobilize the patient and then do your physical exam, okay? Don't, in reality, have someone hold C-spine and then do a physical exam. Go ahead and immobilize them and then do the physical exam. In reality, you would wait on the physical exam. CMS checks, do your immobilization, then go into your physical exam on the way to the hospital, not sitting in the house. Palpate and examine the neck, make sure the trachea is midline and there's no crepitus or deformity in the C-spine. Okay, so there's a bunch of pictures here that we'll shoot through right quick. But all you're doing when you're doing these different movements is you're doing an assessment on different spinal nerves. Okay, so you would do a flexion, see if they can move their arms up here, move their arms here. I don't necessarily. Oh, let's move here, then move here. Move your arms and legs. Okay, you're good. Right, to speed the process up some. But anyway, extension, finger abduction. This is testing, and it's been too many moons. I can't remember what each one of these correlates with the nerve. Okay, can I borrow a hand? I need to take it off. Is that okay? Okay. No, I need your hand on there. So it's. Okay, so I'm gonna. I'll come up here. Smile. Up. I'm gonna want to keep me from moving your fingers apart. Okay. No, keep me from doing it. There. Okay. So see, I'm trying to pry her fingers apart. Okay. So that means that particular nerve is intact. Okay. Now let me pry them apart. So if I can do that and you're trying to keep me from doing that, that means that nerve's not intact. So that would mean, okay, I'm going to backboard you. Okay, you just failed this part of this spinal test. All right? Okay. That's very important. Fingers, make sure you move your fingers up and down. Wrist back and forth, extension and flexion. Like I said, can you move everything? Down the feet. You want to push down like you're pushing on the gas pedal and pull back, right? Plantar and flexion, plantar and flexion, okay, on the feet. And then we want to make sure that you can feel touch. Now these guys take in the pictures here, they take like a Q-tip. Good luck with that. We don't carry Q-tips on the ambulance, okay? But if you suspect, feel my hands, my arms, okay? Then, you would start at distal, start at the hand. You want to volunteer for this? Okay. I just need one arm. So you say you can't feel here, so you're numb from your shoulder down, okay? Now, I could do this and say, no, I can't feel this. But typically what I do is take a small needle, okay, and I start sticking. Don't go up your arm with the needle. Is that okay? Ready to take one for the team?
Wait, let me pray for a second. Okay. Lord, please don't let me die today.
This is a journey needle too.
Lord, thank you for another day.
Anyway, I take a small needle and I stick, and where they can feel sensation, I document that. Okay? If it's up the leg, I go all the way up the leg until they can feel sensation. Okay? So you want to check that in your exam. Okay? And they're just really small needles. So, like a 27 gauge needle or something. All right? Because what happened is, people say, I can't move my legs, right? So what question would you ask them? They say, I can't move my legs. Hmm? Yeah, can you wiggle your toes? No, I can't move anything down there. What would be one of your questions? This is a tough one. This is not as simple. I said, let's say I had enough of all this, and I was up on top of the roof. I was about to jump, but I slid down on my butt. I said, man, I can't believe my legs. I can't feel my legs. I can't move them. I can't move them. I can't move my legs. What would you ask? Can you move other parts? Can you move? You're close. The question is it that you can't move, or does it hurt to move? Because some people won't move when it hurts to move. They say, I can't move. Okay, you physically can't move your leg, or does it hurt when you move your leg? You have to get those two things out. Move your leg, and then you get down to the thing, well, it hurts too much to move. Okay, so you can move, it just hurts to move, right? So that's a big, okay? Anyway, so go through this sensation, log roll the patient up, palpate the spine like we just talked about, go down, palpate each process on your way down on the spine, and then always watch, be aware of neurogenic shock, okay? Obtain a good history on what took place, try to visualize, get a good mechanism of injury, visualize what's happening there, okay? Make sure that you understand that if they have deficits before, okay? I can't feel my legs. What would be a question? It's sort of you might put it in the stupid question category, but it sums up, because we don't make assumptions, right? Keep that in mind for the answer. That was a hint. I'm sitting here, I was injured, and I said, I can't feel my legs.
Okay, would you like try to touch their leg to see, okay, can you feel this?
What do you think? Common sense question, sort of. Very good. Yeah. Exactly. Can you feel your legs before? Okay. Some people have a history with it. They can't, you know. Maybe they get, I don't know, you know, you could if this to death, but, you know, they may not have sensation before. So you have to make sure that they had sensation before the incident. It seems it's sort of a weird question, right? But it takes out that assumption. Okay, so anyhow, so some signs and symptoms of this spinal cord injury: obvious tenderness, deformity along the line of the spine, pain associated with movement, pain independent of movement on palpation, deformity of the spine, big, huge soft tissue injuries around the spine. Okay, you want to. That's sort of a higher suspicion. Okay, numbness, tingling, any neurological deficits here, loss of motor function, big time here, loss of bladder or bowel control is a huge one. Then, have I told you guys about the Parkland handshake?
No.
Let me get to that later. Remind me, tell you about the Parkland handshake. Okay, it's important. Priapism, that is a unique injury that is a constant erection in males. Okay, I haven't ever seen that pre-hospital. Just I've seen it in the hospital with people were brought in with spinal cord injury. This is a positive sign of a spinal cord injury. This is a loss of bowel control. Unless they just had to poo right before the accident, then that's probably a spinal cord injury. Okay? So those are some signs and symptoms of that. Like I said, only maybe twice. You know, it's such a weird injury. Okay, I have no idea what makes it do that, but okay. So GCS less than 15. So if they're altered, if you suspect a head injury, altered mental status, like folks, why would you have to immobilize that person with alcohol and drugs?
Well, again, they probably can't respond to you.
Yeah, they're not going to give you a good neurological history, tell you about where the pain is. Okay, so you can't trust their judgment. Okay, and then distracting injuries, they can't communicate. Okay, if some complications to this, like I said, if the spinal cord injury is above the nipple line, they may not be breathing at all. Okay, C1, C2 fractures. While we hold C-spine for big time, it's these C1, C2 fractures. They're called again, back to trivia. Back in the day, they're called a hangman's fracture. Okay, because like we talked about, that knot snaps the neck. That big knot sits right underneath the occipital lobe, and when the cattle rustler drops through the what do they call it, a gallows, okay, that knot pushes their head forward and snaps their neck, okay, and then they die quick, okay, or they stop breathing right then. All right, so now it's called the Superman fracture. Any reference? Y'all remember the Superman fracture? Christopher Reeves, he's dead now. He went over the front side of the pony. He was doing something, he was jumping that stuff with the horses, and then the horse threw him off the pony to the front. When he landed, he fractured C1 and C2. Okay? What it doesn't show on TV, because I've done it, while those horses are running, there's an ambulance that's going around with them, around the track. Okay? So when Superman got thrown off his horse, the ambulance was right there. Okay? So they went up and said, don't move, and hold C-spine. Okay? And then, because he fractured C1 and C2, he was on a vent, wheelchair, he was quadriplegic, right? So he would have died just like most people die with C1, C2 fractures, except that there was an EMS standby there, and they held C-spine and controlled his movement, right? Most C1, C2 fractures happen on the side of the highway, the deaths do anyway, the fatalities, because they're talking with each other, they have relatively no pain, and they do this. They turn their head and look over at their car or whatever, and they transect their spinal cord at that level, and then it's pretty much ball game over if someone's not there to resuscitate them. Okay, that happens, not a lot, but it happens. I had to write it down because I always forget. C1 is called the Atlas, like holding the world up on the thing.
Yeah.
Because it directly connects to the skull, so it holds the skull up. But C1 allows us to do this, and then C2, the axis, allows us to go side to side. Again, really trivia, but I thought it was worthwhile for a moment. Okay? So that's what we're guarding against a lot, is these cervical fractures, but we're really guarding against C1, C2 when we want to hold C-spine. Okay? Okay, so paralysis, Quadriplegia, this word here is just another form of quadriplegia, quad 4, right? Hemiplegia, paralysis on one side. If the vasodilation leads into shock, and we've already went over the warm, dry skin and the mostly normal heart rate, right, for that. And we went over this too. Since this is about 2013, they really started changing the thing with backboards. We just don't backboard as many people as we used to because of the one. I think it's mainly because of the manipulation of the spine. When you're in the emergency department, you see them getting them off the backboard pretty quick, right? They come in on the backboard, the doc comes in and evaluates the spine, and then he'll pull that backboard out. They may still go to x-ray to confirm it, but he's going to remove that backboard, or she's going to remove the backboard, okay? They're going to try to get that backboard out. They do several different tests. This test was just one of them. Okay, there's other tests that you do to clear the spine. You shrug your shoulders, you stick your tongue out. They're all checking cranial nerves and spinal nerves. All right, push down on your feet, you pull up on your feet. There's a couple more I can't remember, but the C-spine clearing or the spine clearing is really a protocol issue. Okay? But if there's any mechanism of injury or any suspicion, then you can't clear them. Okay. No. Yeah. And now, I mean, we'll go and we'll do the rest of this is just doing the spinal mobilization. We have two skills here that we need to pick up. We need to pick up the long back, the backboarding, which you guys have done some, okay? And then the KED that we'll pick up next time. We'll work on the KED next time. And the traction splint. So we have a few skills to do. Questions? Everybody good? Okay. Here's your skill sheets with it.